Welcome, everyone. My name is Nate Knorr. I'm your host of Perfecting PT, and today I'm joined by Dr. Zach. Is it Leal or Leal or Leal?
We grew up saying Leal. When you get around some other people, they pronounce it Leal. Either one works.
Okay, but you grew up with it being Leal.
Yeah, correct.
Okay, got it. So we are joined by Zach Leal. He is the owner of Forged PTP. So is that what is it physical therapy and performance?
Correct.
Okay, awesome. So yeah, we have Zach here from Forged Physical Therapy and Performance in Southern California. Um, and he was nice enough to respond to some of my messages this last week. He has kind of listened to another episode and thought he had something to offer. So, Zach, I'd love to just know a little bit more about you and anything you want to add for people before we get kind of going.
Absolutely. Yeah. So owner of my own clinic. It's been a fun ride. Kind of my mantra, or I guess quote unquote mission, is to try to bridge physical therapy and performance to have it a homogeneous relationship for the patient to try to kind of bridge their gap however they see fit. My
Sure.
whole goal was, hey, if God forbid, if somebody comes in post-op day zero to completely return to sport or return to activity, I want to be the person that can float across all those continuums.
Sure.
Obviously, there's very good experts in all of those stages, and I'm not saying that I'm going to be the best in any one of those stages, but more the fact is I want to be able to have enough ability to be dangerous for anybody that comes into the clinic. So that's kind of my quote unquote mantra. Like I said, in Southern California, I'm inside of a baseball training facility called PFA. I've been a part of that gym for a long period of time, which we can get into some more nitty gritty details there. But yeah, so I have two different offices and just trying to do what we can to try to treat again, that's the new kind of social media thing, but treat athletes where obviously, yes, we treat people that play sports, but we try to treat the general population because we see them as athletes as well.
Sure. So, did you open your clinic right out of school?
So yes and no. So for the most, I guess, when you're graduating school, there's obviously boards and all that fun stuff. Most people are either going to go residency and all that kind of route, or they're just going to go get their job.
Hmm.
I took my last clinical rotation, and I kind of consider that as my residency. Obviously, that I don't mean that as a slight against residency and all that type of stuff, but I did my last rotation at Champion PT and Performance up in Boston with Mike Reinold and Lenny Macrina. Very high level sports specific clinic.
Mhm.
It was a crash course into what I wanted to do, which is great. So I decided to go do that, and then I got a full-time job. So I was working full-time, doing the whole thing, clinic, high volume, in a clinic that I wanted to treat. It was awesome, great. I also was working on the side as like a side hustle right out of
Mhm.
school and kind of doing that. With the setup that I have and the long-standing relationship that I had, it was kind of like this two different things at the same time. So it wasn't one of these things where I just walked out and I was like, oh, hey, let's open a clinic. And then, oh my God, here are all these patients. It was, no, I'm going to go get my reps and I'm going to treat everything I possibly can because I felt it was very, very important to test my theories, test my skills, wanted to see if I knew what I knew and if I knew it, wanted to work with
Mhm.
some people that were smarter than me, and it couldn't have worked out any better.
Awesome. Yeah, I ask because that seems to be a big because you've been practicing. You told me right before we started recording almost 4 years. I've been out of school a little over 2 years, and I know a lot of people that listen. At least I'm hoping this is getting to students, and a lot of them are debating with the idea of, or at least playing with the idea, like, should I start a clinic right out of school?
Oh,
And my
absolutely.
general And of course, like, of course you can. There are people who do that and do it successfully. I agree with you, Zach. It's like, go out, find a good mentor, get some reps, make sure you actually know something. Because if you end up starting a practice and turns out you don't actually know what you think you know and you're not getting outcomes, like, you may not be able to maintain a successful business.
And there's so many layers on that, and I'm gonna sound like a hypocrite, and I have no problem saying that out loud, is that if I were to do it again, would I have done it differently? I don't Not really. Would I
Hmm.
have spent more time trying to kind of build different relationships knowing what I know now? Absolutely. Would I have spent more time maybe going and doing more Con Ed or doing that? I don't know either. But what I will say is knowing what I know now and the new sorry if this is too aggressive, but the new sexy term on social media now is like, oh, you're just gonna go start your cash pay
Right.
clinic, you're going to do all this stuff. Oh my God, you're going to make bajillion dollars and it'll be okay.
Yeah.
And I really, really hope that the people that do decide to do that, which it is possible, and I'm not saying that, and I'm not discouraging away from it. It's at the same time too, is you have to be good at it first off. So like it's a service-based industry. We are here for the patient. And
Mhm.
if you can't facilitate any of that situation to begin with, it's going to be really hard for people to kind of come back and continue to pay you X amount of dollars. Not to mention
Right.
is that then if you don't know how to run the business side of things, then there's a whole cluster that comes with that as well. So I am cautiously optimistic for future professionals and future students to decide to open up their own clinic, but it's one of those things I'm like, I hope that there's some sort of guiding factor or guiding guardrails for that clinician that decides to do that. And obviously, if you have any questions or anybody who are listening to this, feel free to reach out. I'll be more than happy to share experiences and obviously with this podcast and stuff like that. But yeah, it's a it's a hypocritical stance slightly.
Nah, I don't think so. I think a lot of people once if you most people once they've done something, there are things they would change.
Yeah,
Like they look back and they're like, well, I didn't know what I didn't know. It's like,
yeah,
but looking back on it, like I probably would have changed a couple of things to make things turn out a little better than they already may be.
yeah.
So for anyone listening, um, Zach, so from what he's told me, he works with, so obviously he's in a baseball facility, but he also does a lot with CrossFit. We have decided on this episode to focus on baseball because if we try to cover too many topics, we're going to spread ourselves too thin. And
Yeah.
and you as the listener, like we want to make sure that every bit that you listen to, you get something out of. We were talking about before the podcast how annoying it is when you are listening to a podcast. It's 30 to 45 minutes, maybe it's a performance podcast or whatever, and of the 45 minutes, the part that even if it's an enjoyable conversation, there's like 5 minutes where you're like, if I heard just that,
Yeah.
I would have been happy and I would have moved on with my life. So we're trying to make this podcast, however long it lasts, um, have as much of our conversation as possible fit into that. That was useful. I'm going to think about that. I'm going to toy with this. And I feel like I'm better because of it. So we're going to start off our episode talking a little bit about Zach's background, his kind of preferences towards treatment styles, types of programmings, education he's got. If you're not watching the video podcast, in his tag, he also has that he's a CSCS. How long after you graduated did you get your CSCS?
So funny story
Or
about
or
that.
before maybe?
So funny story about that. I wanted to get it before school, got into school. I did my PT school at NYU. They
Okay.
require it to graduate. So we had to take it. It
Oh,
would have been the
interesting.
summer. Yeah, it would have been the summer after my first year. You have to sit down and you have to take the test. And it's a cool kind of thing that that program does. And it was something that was very attractive when I decided to go there and do that whole thing. So it was awesome.
Yeah, so you got it during school. That's
Yeah.
interesting. So, I guess let's talk about your kind of treatment preferences. Like I know
Yeah.
on an earlier episode, if people listened to the one with Emily Faree, who's one of the PTs who helps a lot with the Chargers, like she did like the Posture Restoration Institute, like PRI. Like, what are your kind of fundamental like either beliefs or principles that kind of guide your process, whether it's a course or things that you've just kind of picked up from your own experience?
Yeah. Okay. If I get too wide on this concept, please wrangle me back in.
Oh,
But I'm a person
this will
where,
be hard to keep contained. It'll be fine.
so I'm a very observation based person. So I grew up playing sports. I played baseball my whole life. It was a cool whatever. That's why I kind of did this whole baseball thing. Story for another day or another topic. As I was going through school, I was very aware of like taking the lessons that I learned in baseball and trying to triage that into my professional life. So like, hey, we had different coaches for different things. Awesome. So why would I not learn from a bunch of different PTs doing a bunch of different stuff? So
Mhm.
I tend to kind of sit in the camp where I take bits and pieces from a bunch of different things and then I try to kind of mend it and make it my own thing. So since you kind of brought it up, I understand PRI. I read up on PRI. I read up on McKenzie. I read up on Charlie Sermon. I read up on all these different types of philosophies.
Can I
And
pause you for a second there, Zach?
sure.
You said PRI, McKenzie, and you said something that didn't quite come through very
Oh,
clearly.
Sermon, Charlie Sermon, right?
I'm not
No.
familiar with it. For anyone
Okay.
who isn't sure, like, could you maybe tell us what that is?
I really hope I'm not pronouncing her name wrong, but she's kind of like if you're going to make a Mount Rushmore of physical therapy, she would be on it. So she was a very big component of movement. The quote unquote movement is medicine.
Sure.
So very pain is the driver of not allowing a movement. So then therefore you help the patient facilitate said movement. Therefore pain will reduce. Therefore
Mhm.
progression from there.
Got it. And you said
So
her name was what?
it should be. I
No, no, no.
can't
Don't
not
don't
look
even
it
worry
up,
about the
but
pronunciation. Can you just spell it?
um, Sermon, Serman, Charlie. Yeah, it should be Charlie Sermon.
Shirley Sherman. Oh no, just so
Yeah,
people, if they're listening, they're like, oh, I hadn't heard about that. So it doesn't matter if you said it
yeah,
right or whatever. They'll Google it, and some things will pop up. Okay,
yeah.
got it.
She's highly, highly. If you type in physical therapy and her name anywhere close, it should pop up with a lot of different things. So I
Got it.
apologize if I am mispronouncing that to anybody and whoever is listening. But
You're good. If she ever
um,
comes on and gets after you, I will defend you.
well, yeah, absolutely. But so going back to that, so I like to take bits and pieces from everybody. So I try to kind of make my treatment approach where I'm looking at it from a very realistic standpoint of like, okay, what's in front of me? And I'm not going to marry myself to one topic because one of the best things that a mentor told me is that you can't have one thing that works for everybody. So I've kind of taken that approach where it's like, hey, I can have a bunch of different options, a bunch of different availability for treatment styles. Let me see and kind of tease out how this person is responding to different types of techniques. And then I drive that home and kind of work them through their goals that way. So to answer that question, it's not necessarily I have like one treatment style, but within the different diversities and places that I've been and CIs and mentors and this and the other is I try to tend to lean back on principles and foundations. I don't try to lean back on techniques because I think that can kind of sell yourself short from a objective point of view.
Sure. Well, and I think that highlights the purpose, like the importance of a mentor. Like you getting to witness. So obviously, like what you can observe, no matter how smart you are, is very limited. If you can get
Correct.
on with a mentor who already has observed and hopefully had mentors who they observed, like you can expedite the process and you can really kind of skip the observations that you likely would have eventually made, and you can expedite that to know it in a much shorter amount of time, which overall is better for you and for the whole physical therapy community. um, so I know, like, for um, a lot of times with my patients that come in, most of the time I do not treat upper quarter. I would say 90 to 95% of my patients are lower quarter, low back and down. Um, and a thing that I'm constantly both reminded of and I share with my patients as I go through my evaluation is like, I feel in particular, like the lower quarter, like it is a system. Do
Yeah.
you have like phrases or beliefs that you are regularly expressing to like patients if they have questions, or other healthcare providers? Like it sounds like one you like is movement is medicine. Like we want to get those segments moving, like returning to, like, get them doing as much as they can as a means of reducing and improving their pain. Um, any other things that you're like, yeah, I say this a lot, or I kind of base a lot of my beliefs off of X, Y, or Z. And if it doesn't pop up now, it'll pop up later.
Yeah. I try to not use catchphrases. It was one of those things like in school, like
Sure.
the motion is lotion, movement is medicine,
Hmm.
PT toolbox. I like shout out to my boys that were sitting in our classroom in the back. Is like I just couldn't do it, and that's not
Yeah.
how I kind of like drive. And no disrespect towards you or anything of that nature,
Sure.
but it's one of those things where I look at it and I try to kind of get with the patient. So like there might be that's gonna sound kind of crazy, but like every patient has their own personality or how they kind of respond to certain things. So like
Sure.
I'm not trying to impose my jargon or language on top of them. I'm trying to kind of receive what they're saying. So if this person is very like hyper tense and they're super like pain is driving everything, and it's like I'm not even going to talk about pain because I don't even want that concept to kind of come into their head. I'm gonna like,
Mhm.
hey, here we're gonna go to the side and we're gonna talk about their dog or this, that, and the other, and then I'm facilitate that way. So like I don't know if I'm answering your question directly, but it's more the fact it's that I'm trying to always manipulate myself to the best of my abilities to then be the best person I can for that patient.
Sure.
Unfortunately, with my time frame and I'm one-on-one for an hour with all my treatment sessions, is that I have that time availability, which
Mhm.
if we want to get into business practice and stuff like that, we can later. But it's more the fact is again, I'm just trying to marry a bunch of different like concepts and topics and trying to be a soundboard for that patient versus like, oh, hey, your body is a, I don't know, is a car, and here's this metaphor. Yes, I still use
Sure.
metaphors like that. Like, I guess if I were to kind of boil it down, it's I'm using like batteries is another like one. So it's like draining the battery. How do we recharge the battery? That's your recovery.
Mhm.
That's your sleep. That's your sleep hygiene. That's your food intake. I would say that's a big one. And then another metaphor is like a bank balance, like checking accounts. I use that metaphor a lot. But ideal
Mhm.
is I'm just trying to kind of create language to level with the patient. So for instance, like a 10-year-old kid, because I treat a lot of youth athletes. So a 10-year-old kid understands the basic concepts of a bank account and things like that. I'm probably not going to use that language for a 50, 60-year-old human being that's trying to get back to CrossFit. So like I said, to answer your question, it's I'm trying to be the best person I can for the patient that's in front of me with my language use, because I think language use then drives their perception, which their perception then drives their outcomes in a weird connection way.
Yeah. No, and I think that's a great answer. And and again, you never have to apologize. Like, even if you are saying things negatively about other people, that happens sometimes. I mean, we want to say that's not true, but then you open up social media and you're like, oh, there's a lot of
Oh,
crap talking going on. So yeah, so like, and that's the whole purpose of this podcast. Like, you can be as blunt as you want because you get
yeah,
good outcomes. You
cool.
get good outcomes, and we want to know what you do.
For
And if
sure.
you think that everyone who says X, Y, or Z is dumb, great. You have every right to say that. And it's like,
Cool.
and if you're one of those people who does X, Y, or Z that Zach thinks is dumb, don't get butthurt. Okay? Because if you get good
Totally.
outcomes, it doesn't matter. It's like, take the things you can learn. It's like, all that matters is the outcomes you get with the people that you have direct contact with. It doesn't matter what anyone else says. It's like, so
Correct.
if you don't agree with any something that me or something that Zach says, it's like, if you're getting good outcomes, who cares?
Do it.
If there's people you're
Keep
struggling
doing
with
it.
and we talk about them and we say something that we do to get good outcomes, maybe play with it. It's like, this is not a contest. And if it is,
Agreed.
it's just for everyone to get better outcomes. So I feel like I cannot emphasize that enough. Like, if you're getting good outcomes, don't get butthurt when someone disagrees with you. It's like, because that just comes off as you being defensive. Um,
Agreed.
okay, great. So thank you, Zach. So,
Yeah.
how old are a lot of these baseball players that you're dealing with? Are you working with like a lot of like high school, college age guys? Or are you doing any like pros, semi pros? What's your kind of population like?
Yeah, I mean, I flipped the whole continuum. So I think the youngest person that I leave out in my office was 8 years old, and then I've treated all the way up north of people that have played in the major league. So kind of that whole continuum, and then that's just in the baseball realm. And then obviously I have other patient populations where I still treat others in that realm. But sticking to that baseball kind of theme, it's I've treated the whole continuum, every which way, every league, every this, that, and the other, and then obviously baseball and softball. So that's going to be kind of another topic of conversation as well. But yeah, so all the above.
Okay. And we'll kind of see where this question goes. What do you feel? It seems, from my perspective, when patients come, like if a patient has back pain, there
Hmm.
are a number of patterns, whether or not I tell them anything, there's a number of patterns like, oh, they are likely going to have a deficiency with X, Y, or Z. Do you find that with baseball players, there's kind of these things you're like, chances are if they come in like with a lower quarter issue or an upper quarter issue, they're going to have one of these 10 issues. And I repeatedly find this. Um, do you kind of have some of those you could tell us about?
Oh, absolutely. Yeah. So I'll kind of generalize it kind of by age group slightly, and then it'll, like I said, hopefully
Yeah,
we'll
that
kind of
would be
mend
awesome.
together.
That would be awesome.
So I'm going to start with my younger population. So baseball is a funny sport because it's one of the few sports that has a very stressful movement involved in it. Obviously, there are other sports that have stressful things upon it, but throwing a baseball is literally the fastest recorded movement that a human can do, like ever. So, okay, there's inherent stress with that. And stress as a noun, not as a negative. Cool. a 5 ounce weight. It's a weight. Like, I'm sorry, it's a weight. It is what it
Mhm.
is. So when you induce high velocity and high stress, that's going to create adaptive changes across a person, depending on how long they play and when they start playing, but it'll create some sort of systemic change. So for my younger population, I would say kind of the biggest things I'm super worried about, and obviously again with my time frames on how I treat, I can kind of dive in deeper into these things. But lower extremity weakness is going to be like, I would say across all my patient population, is probably about 80% of everything. So like when we're talking about kinetic chain and transfers of energy, if you don't have a good strong base and a strong core, then leaking energy everywhere else. But with my younger population, it's definitely like movement accuracy, lower extremity weakness, and then that kind of translates into poor scapular mechanics. And again, I don't like using these big bucket terms, but
Sure.
scapular dyskinesia is going to be this thing that like everybody knows, but nobody really knows what it is. So that's going to be kind of like your one things. And then obviously where those stresses then lead, whether it's an elbow pain or shoulder pain. So I would say like if I were to kind of bucket the younger kids, it's going to be lower extremity weakness, core weakness, lack of stability, and just not able to tolerate stress very well because from a strength standpoint, because they're not really developed. As they move through kind of the age line, kind of that high school age kid is most of the time it's I'm trying to kind of figure out where they're kind of going or what kind of stress is getting induced onto their body. So that's where you get to see a little bit more orthopedic stuff. So like younger kids, it tends to be elbow pain. That's going to be like your number one thing that you probably tend to see the most. Little league elbow. As you kind of move through, as they get older, things start to pop up a little bit differently. So you could get some like spondies, you could get some shoulder pain, you could get some of these kind of other orthopedic issues that you kind of have to then decipher if it is a strength issue, if it is a mobility issue, if it is XYZ. So I would say with that high school age range kid is that like my big thing that I'm looking for is rotator cuff strength, and if they have it. Velocities tend to increase over a time frame or over their lifespan. That's kind of when the breaking points start to happen, whether it's bone versus ligament injuries because of the way that the biology works and puberty and all that stuff. So rotator cuff strength, I think, would be like my biggest thing I'm looking for in that mid range, that mid age athlete. As I get into the older ones, now I'm more worried about just longevity. So it's not necessarily that I'm going to like be able to completely I don't want to say it's not that I'm not going to be able to completely fix somebody, but a lot more wear and tear on the shoulders, a lot more wear and tear on the body. Their goals are, hey, I need to sign another contract and I might have 1 or 2 years left. I just need to kind of mend some stuff together to basically decipher this out. Or the other side of that is like, hey, I need to try to fix this 1% thing because that 1% thing can possibly have me sign for $10 million. So
Mhm.
it's now we're getting into the really nitty gritty of like, yeah, it's not these like global orthopedic issues. It's this now performance side of things. So I think that kind of goes back to the mantra earlier, where is that I'm trying to completely bridge the gap between PT and performance.
Sure. So, a couple things. So, with the younger kids,
Yeah.
the concern is elbow. We know there a lot of these younger kids get Tommy John surgeries. Some even do it electively to try to reinforce that elbow, which is
Yeah.
not a good
Yeah.
idea. But so high school, we're kind of looking at rotator cuff strength, and like you said, college, kind of older adult age. You're looking more like longevity. Like they want to continue playing, they want to continue to get. If it's a pro or some type of contract, trying to get a contract, like being able to play long enough. Um, so starting with the younger kids,
Yeah.
do you find that the lower extremity weakness is more just global because they haven't done resistance training, or do you find they have some particular limitations, like maybe their single leg balance sucks, or maybe their like hips are really weak, or maybe they just aren't good at rotation? And like are if we kind of go down your list, like is it global, or are there kind of some specific things that these kids are really generally weak at?
So I'm going to give you the best answer ever, and
Yeah.
I'm going to say
Heck yeah.
both.
Heck yeah.
So I think particularly like particular movements and particular strength, I think leads to global deficits. But I also think like global movements are also not cohesive, for the lack of a better word. So for
Mhm.
instance, like younger kids from a biological standpoint is like especially in today's age, is like kids aren't playing as much. They're becoming more and more specialized. They're becoming like professional athletes by age 10. So the movement diversity that they've experienced from a pure life standpoint is not as greater as it used to be.
Mhm.
Can I extrapolate that that is now leading to all these injuries? I don't think they are, but I think there's some correlative factors there for sure.
Sure.
So, single leg balance and like when I go through my movement screen and my evaluation process, like I have a systematic approach where I literally check off boxes, good, bad, different, whatever, grade, everything. So one of the things I am looking at is glute strength. I am looking at single leg balance. I am looking at all this stuff. And most of the time on the younger kids side is like it tends to be a little bit more on the poor side.
Sure.
With that being said, is that I don't know. I think it's more of a maturation issue, not
Mm.
necessarily like they aren't good at it. Like I think if you're going to take every 10-year-old kid, I could probably make the argument that their glute med is weak on their landing leg. I could probably make that argument for 95% of the population. So trying to kind of be as objective as I can with subjective like viewings of things is like again, it's I think it's tends to be both.
Sure. And maybe, yeah, I'm going to pivot a little bit because
Yeah.
essentially I'm going to ask questions that delineate kind of your process. So I would love to, um, let's talk the subjective briefly. Like if you have a
Yeah.
throwing athlete, particularly in baseball where there's very high velocities involved,
Yeah.
when someone comes to you and let's go through, do you find that most of them are dealing with like shoulder girdle pain more than other issues?
Uh,
Like how often, like, and I know this, it's not an exact science, but just for us to give us like a hypothetical patient,
mhm.
like, do you find that more people have like shoulders, more people have backs? Because there will be some backs, there'll be some hips, there'll be some knees, there'll be some
I
ankles.
see what you're saying.
But do you find that most of them are probably like thoracic slash throwing arm dominant injuries?
Oh, yeah, for sure. And
Okay,
I think the way that I treat is again, I'm trying to treat the whole body all at once. I know that's a
absolutely.
tall, tall task, but yes, I would say majority of injuries are going to happen on their dominant side. Yeah, we can talk about the non-dominant, but we'll leave that for another conversation. But
Sure.
most of the injuries that are going to happen from a throwing perspective are going to be happening on their dominant side for sure. Where I kind of take the one step further approach is that most of the time where the pain is happening, it might not be why the pain is happening.
Heck
So it's the
yeah.
what versus why. So again, looking at the whole body approach and going back to this whole thing, like single leg balance, glute strength, like yeah, that's a big factor. Okay, if they can't do that, is it going to lead to proper or improper shoulder mechanics? Absolutely. Is the improper glute strength completely related to the elbow pain? Not necessarily, but it's a factor. So it's again,
Sure.
now I'm kind of like I'm trying to find buckets or the lowest hanging fruit. Going back to your metaphors, like if I can say like one thing that I say in my practice all the time, it's lowest hanging fruit.
Mm.
What can we take care of as quickly as possible, as soon as possible to make the biggest bang for the buck as quickly as possible? So lowest hanging fruit, fill those buckets as quickly as possible, and then tend to kind of move on from there. So like, yeah. So to answer your question, like, yeah, it's definitely on the dominant side for sure, but it's I'm trying to kind of take all the information all at once, and then going from a subjective point of view is the biggest lesson that I've ever learned from one of my mentors in regards to a subjective is if you ask the right questions, the patient will tell you what's wrong. You just have to
Mhm.
listen. So I have keywords and things that I'm looking for or hearing that if a kid says this, okay, cool. Now I have another set of 50 questions that I'm going to ask. If a kid says, hey, my shoulder hurts in this spot, cool. There's another 50 questions. So from a subjective point of view is I'm trying to let the patient tell me as much as possible and then use my quote unquote active listening skills to then try to decipher kind of what's going on.
Sure. So let's take a hypothetical um, upper extremity pain
Yeah.
person. And I
Hmm.
I will start off by saying this. I love also I am sitting on this weird like leather chair. So if you hear it squeaking, like sorry about that. Um like I love what you said. You're like where the pain is isn't necessarily the problem, but potentially the result of a cumulative like of an accumulation of problems in a complex system. Like, and I think that that is often overlooked or kind of undervalued. a lot of
For
people are like,
sure.
well, the back hurts. The back needs to be strong. Like your back's just weak. It's like, or the back is the victim of so many other problems that like need to be found. That like, that's why we have a doctorate. Like, that's why we need to have a vast understanding of multiple systems and be able to, think about complex problems. So let's, for the sake of our kind of pseudo evaluation that we're going to walk through to
Yeah.
give people an idea, like let's say someone is coming to you with upper extremity pain.
Mhm.
Oh, I want to do this because I don't treat baseball players all the time. Okay, so the big buckets, I'm assuming you said elbow's a big one.
Yeah.
I'm assuming shoulder is a big one.
Correct.
Why don't we talk about on a general level, and it may be difficult, so we'll manage it as best we can. If someone comes to you, let's start kind of around like the shoulder blade, and let's kind of work like T-spine, shoulder blade out to the shoulder, down to the elbow.
Okay.
If that makes sense. And if so, we'll start with the shoulder blade. Like, what things are they going to say about the shoulder blade that actually, in your opinion, give you anything to go on?
Okay. So I'm not going to completely derail this, but
No,
from
feel free to
going from a
go however
specialist,
you want.
so from a specialist, like other systems and things like that, like I'm going to kind of just say, like, let's just say, I'm going to set the scene where it's a 12-year-old kid. He comes in to see my office or into me at my office and he says, hey, I have medial elbow pain. I would say that's probably 80% of the kids that happen that
Okay.
come in. Cool. We roll through the subjective. It happens when I throw, it happens after I throw and I'm pitching this, that, and the other. Okay, cool. First off of kind of what I'm going to do is like, all right, let me go back to the other system thing. So if they have like thoracic spine pain, other systems is like, hey, dude, like you have to kind of tease that out because like that's not a normal finding at any. So now I'm like worried about like thoracic cavity issues or God forbid if it's like a heart thing or a lung thing. So like that's not a normal kind of pain route. So that would be like,
Oh, okay.
okay,
Okay. No, that's a good thing. So most baseball players or most overhead athletes are not going to have like rib cage
yeah,
thoracic
that'd
pain.
be
Got
correct.
it.
Yeah. So
Okay,
that would be
great.
like, but that goes into the other conversation that you just were bringing up about the doctorate. It's like, okay, like I need to know, like, hey, if there's a kid that has trouble breathing or chest pains or this, that, and the other, and they are coming in to see me for elbow pain, like that's still part of my doctoring profession. And unfortunately, with my license at stake, I know that's harsh, but I have to ask these questions to tease some of this stuff out. So with all my athletes and all my youth athletes, especially, I still do like a questionnaire type screen where it's like, can you use the restroom? Have you done like lost a bunch of weight? Can you feel your feet? Like there's still some of those other system stuff. So I really want to kind of make sure that that gets across where I think some of those other systems and some of those other kind of generalist practice things that we learned in school kind of get thrown out the window in the more the performance based setting where I
Mhm.
really want to make sure that that's upfront and honest right now where I still use those practices daily. So but going back to kind of this setting this premise where cool 12-year-old kid elbow pain is I do a movement screen. So very general basic movement screen where, hey, can you touch your toes? Can you bend backwards? Can you rotate? Can you squat? Can you lunge? Cool. Then I'd kind of take that and decipher, okay, this is a bucket that I want to fill eventually. That's
Sure.
kind of a point where I go over with the kid, with the parents, hey, this, there. So I basically funnel all my evals where it's like it's very general and then more specific. So then going into the elbow, like the elbow is probably the last thing I eval, if I eval it ever, depending on the kid and the age and the pain. But with that being said, is that if I provoke the elbow first, it's going to be so hot where everything is going to be provocative. So I try
Sure.
to kind of get away from the spot that's super, super provocative and eval everything else first. But
Okay.
going into kind of like the movement screen and everything else like that, extrapolate a bunch of information there, kind
Sure.
of then
Can I
go ahead.
pause you for a second?
Absolutely.
I like where you're going. I need to ask the right questions for you to tell me the answers. I'm
Understood.
paying attention. So let's forget the shoulder blade for a second.
For sure.
And let's just hit just subjective because then we're going to go into this big funnel that you use. Um,
Gotcha.
like if someone says like, so let's go shoulder. I think that's more
Yep.
prominent. Like how many locations of shoulder pain really, in your opinion, so like if you have anterior shoulder pain, superior shoulder pain, posterior shoulder pain, like how many of those actually tell you, like, are those actually different things in your mind? Like, are they kind of pushing you different directions? Or are you just saying, oh, it doesn't even matter if it's anterior, lateral, superior, posterior shoulder pain? Like, it's probably stemming from the same, like I'm going to look at the whole system, but does the location of shoulder pain change your mind about instinctively about what is causing the problem?
Yes. So going to your differential diagnosis, absolutely. So anterior shoulder pain, I'm going to kind of get out there a little bit and go a little harsh. So biceps tendonitis is like the number one thing that you see across most scripts. I
Sure.
think it's an absolutely bogus, like pointless diagnosis. I think it's terrible. I don't think it's even what's wrong. Shout out Dr. Meister. He is the team orthopedic surgeon for the Texas Rangers. He says it best. He says that bicep tendonitis is a runny nose to a cold. So
Mm,
perfect example where it's not what is actually inflamed, it's why is it inflamed. Cool,
right.
differential diagnosis. Lateral shoulder pain is probably going to be your more prominent one. Obviously, with the rotator cuff insertion points are going to be kind of on that lateral aspect of the humerus, so that tends to be a pretty hot section for most baseball players. Then
Yep.
it's the deciphering. If it's a younger kid, I'm thinking more growth plate. If it's an older person, I'm thinking more rotator cuff, just from a biological standpoint. Posterior side of shoulder pain, that gets a little bit nitty gritty. Where okay, cool. Now you have some posterior capsular stuff. You have some posterior labrums are kind of this new thing that's popping up somehow that I don't
Hmm.
really know what's happening. I do know what's happening. It's just it tends to be a little bit more prominent recently for some reason.
Sure.
So you get into these kind of differential diagnoses, but absolutely, I think using that skill set or understanding the functional anatomy of a shoulder within vivo of a sport is going to really kind of drive your clinical decision making. Do I end up in the same spot or give the same exercises or certain treatment aspects to treat those shoulders? Absolutely.
Sure.
But that's we'll leave that for another time of this or another time
Well,
of this talk.
and um, no, so that was great. So just quick recap. Like anterior shoulder pain, you will often get a referral for a bicep tendonitis, and I agree with you, Zach. Like I think that is a garbage. Like why is the bicep overcompensating? Like to try to do everything. Like if it is pissed off, which it very well could be, it's like why is the body preferentially overusing the bicep to where it would be irritated? Um,
Correct.
so lateral shoulder, I like that you brought up like younger kids, potentially growth plate stuff. Older people, like you had mentioned in your previous thing, you said kind of high school through older age, like rotator cuff strength. Like, and again, why is their rotator cuff strained? Like, are there scapular mechanics missing or other motion where the rotator cuff is now having to manage greater loads and greater movement than it should for them to perform, these high velocity things? Posterior shoulder, you brought up like posterior capsule. Um, a lot of the rotator cuff is kind of going over that area, some posterior labral things. But again, it's like if something is irritated or if something is injured, what predisposed it to being overloaded? Like, why is it like what about how they move is putting additional stress or forcing that to become irritable? So I think that was a great overview. So let's talk about the system you were mentioning because you said you're like I can kind of have this list. I go down it in order every time, check my boxes, and it really gives me a good view. Would you mind kind of walking us through that?
No, not a problem. Yeah. So just to kind of preface and hopefully this reach some students is I just recently had a student in my clinic from USC. And the reason why I use a systematic approach, because like in school, they kind of teach you like, hey, these are all the tests, and then it doesn't really matter when you do them, yada yada yada. I'm on the complete other end where it's like, no, I want this order because it tells me a story. And
Me
like
too.
I know that's kind of basic, but like cool. It tells me the story, but then also too that I'm gonna get the most information out of it. Most of the time it's just for me to not forget anything. So like I have an approach where it's like, okay, cool. If I have an elbow, I'm gonna eve out everything else first and then I'm gonna go to the elbow. Or if it's a shoulder, I'm gonna eve out everything else first and then go to the shoulder. But I'm gonna work through everything to the point where one, I'm not provoking any like hot structures. So if it's an elbow pain, if I like I said earlier, is that if I eval the elbow first, everything's gonna hurt. So then I get false positives on everything. So I digress on that. But my system is so general movement screen. So I want to see very basic foundational movements like can we touch our toes? Can we rotate? Can we squat? Can we lunge? Again, that's going to tell me balance. It's going to tell me coordination. It's going to tell me movement accuracy. It's going to tell me uh, directional preferences. It's going to tell me if the person can perceive movement. Because also too with these things is I'm not giving them a lot of instruction. I want to see
Mhm.
what the default is. Hey, feet shoulder width apart. Can you squat? They're like, well, how do you want me to squat? It's like I just want you to squat. So then where I kind of tend to practice, and this is kind of my new. I don't want to say new, but it's my new thought process is that I think the brain does way more than we give it credit for. Like pain and movement perception and coordination. I think the brain kind of powers everything. So, from a treatment perspective, we can talk about that here in a second. But movement screen, trying to get as much information as I possibly can because that'll tell me a lot from just how the person is as a global athlete. Then, from a scapular and kind of that's my next. Like I look at like the trunk, so thoracic rotation and lumbar movement, and that's kind of where then I go there. Then I go into scapular movement, scapular
So I'm going to
active.
interrupt you real quick.
Yeah,
So you start off general movement screen, and for anyone listening, I think it's important. You do not coach a movement screen. It's
correct.
like for anyone listening, like if you're not familiar with movement screen, like you want to see what their default is, like what are their movement preferences, like what body parts do they bias, like do they bias loading this or that. But I have a couple questions. So when you brought
Yeah.
up like can they rotate, are you just having like in like them just standing straight up and just seeing like have them twist to each side?
Yep,
Oh,
multi-segmental
okay.
rotation. There is a movement screen. It's part of the SFMA.
Uh-huh.
So
Okay.
so now I'm picking apart little
Yeah,
bits of
sure.
it, a
Some
bunch
of
of
that
different
stuff.
practices. Yeah, so like I use it for everybody. So like yeah, again, doesn't matter who it is. I want to see how they move just as a functional human. But yeah, multi-segmental rotation is one of the ones that I tend to use.
And when you transition to more specific, like thoracic and lumbar motion, do you generally prefer doing that in standing or sitting?
Depends. So
Okay,
the
yeah,
movement
sure.
screen, I do it in standing because again, is that I can see I want to see a harmonious thorax, thoracolumbar into hips into femoral rotation. I want to see like a harmonious rotation, right? If I'm not getting that and they're just going all through the lumbar spine, it's like, okay, noted. And then that
Mhm.
then kind of curtails my eval process into like, okay, maybe I might have them do a seated where, okay, pelvis is stable now. Okay, now can you rotate? Does it improve or does it not? Then it's like, okay, that might be a strength
Mhm.
issue or it might be a mobility issue. So then it just it drives my clinical decision making a little bit more during the evaluation process.
Sure. So I'll recap that because I heard it pretty well, but you were cutting out a little bit. Um,
Oh, dang.
so standing's kind of your baseline. No, it's okay. I see
Correct.
you and I hear you fine now, but you just cut out just a little bit, just a minute ago. So like standing's your baseline. You're looking for just this kind of continuous symmetrical like rotation. Like, are the different segments that are supposed to rotate doing it, and are they doing it the way that ideally we think they should? If they're
Correct.
not, it's like then you got to put on your cap and you got to say, why is that not moving? And then, you may sit them, do some active rotation, flexion, extension, passive to maybe see if is it more of a mobility limitation or is it more of a strength limitation? Because if they sit
Correct.
and they rotate and their thoracic spine is garbage, but you grab them and you push them and they go all the way around, it may be more of a strength motor control issue. Like
Correct.
so okay, so just kind of teasing that out. Now, when you look at the scapula, and we're not going to apologize for saying scapular mechanics or scapular dyskinesia because someone's screaming at their radio right now.
Yeah.
Remember what I said earlier if you've listened this far. Like, don't get defensive about it. Um, so when you look at the scapula, like, what are you? I would really like to go through this part specifically, the exam, because you
Yeah.
are skilled, and I want to know what you do differently. So, or what you do specifically. So when you look at the scapula, walk me through what you're doing specifically, and if you want to kind of give little insights into kind of what you think they mean, I think everyone would love to hear them.
Awesome. I will do my very best without visuals. And so if
I mean, if you've got
I can't get
visuals,
it
you I
perfect.
can give you the screen or you can screen share and it'll be fine.
Yeah. So first off, I'm looking and first off, I'd always try to take the patient's shirt off and look at skin as best as I can. Obviously,
Okay.
with certain preferences and genders, I can't do that. But with that being said, is I'm trying to see as much as I possibly can when in reference to the scapula. So I think resting posture is a good starting place. I don't think posture dictates everything. So
Sure.
I'm looking where how much are their scapulas sitting in upward rotation? Are they not? And baseball players are one, they're actually the dominant scapula tends to sit down in a little bit of depression in reference to the other side. So from a static posture standpoint, I'm looking at bony landmarks. Hey, and then I'm getting an idea and kind of I guess comparing them to general norms from an orthopedic standpoint, because again, is that like if you think about it, is that if the right, let's just say he's a right-handed thrower, right scapula is sitting in a little bit of a depression, in theory, they are going to then compensate to get into full upward rotation and or full flexion. So
Sure.
is it the trap that's doing it? Is it the rotator cuff that is just slamming and trying to create more of a hypermobility type situation? Or is the scapula not getting there because the upper chop's doing too much? So that's kind of where resting posture is a big thing. Active range of motion, I tend to do a lot of it where I'll have them go up and out to the side. I'll do a lot of 90-90s just to see again scapular mechanics from an active range of motion standpoint. And then forward flexion all the way up overhead. I tend to look at that as much as I possibly can. So again, is that it's not necessarily very objective. It's just it's me perceiving how they move and then trying to then decipher if that those movement compensations then will play into whatever I think from an objective standpoint matters. So I yeah, I would say that's going to be like my big things again, bony landmarks. Can you get into full upward rotation and then going into your like your 60-120 as far as like your scapulohumeral rhythm? Like I still all use all those very basic stuff. And I would
Mhm.
say if anything, like I don't do anything special. Like I don't do anything crazy. I'm looking at baseline stuff and then the other special stuff comes on the back end.
Sure. So what are your kind of thoughts for the people that are like, well, the research sorry, that's my that's my dissenter voice.
Yeah.
Like the guy's like, well, what about this?
Yeah.
But what do you say to the people that are like, well, the research says that 70% of pro baseball players have scapular dyskinesia and they don't have pain and everything's fine because I know someone will be listening to this and they're like scapular dyskinesia is a myth. Like it
Yeah.
doesn't even matter. And it's like, but it's like, in my opinion, and I'll put in my little 2 cents that you may or may not agree with. It's
Yeah.
like how the scapula moves is going to affect the rest of the body.
Couldn't agree
Period.
more. Could
Period.
not
So
agree more.
if you don't agree with scapular dyskinesia, if someone's scapula moves less and they are expected to get the same amount of motion, the shoulder, that motion has to come from somewhere.
Correct. I
Like
couldn't agree more.
it has to come from somewhere. So like, this is kind of my complaint when people are like, well, it doesn't even matter how they move. It's like, yes, it does. All motion has to come from somewhere. And if it doesn't come from where we ideally think it should, it will come from somewhere that the body may not want it to. Um,
Absolutely.
so kind of
Absolutely.
what's kind of your thought to these people that don't think scapular mechanics or scapular dyskinesia matters?
I think that I think that it's a very poor term for a diagnosis. So again, when
Oh,
you're
okay.
talking to other medical professionals, especially doctors and surgeons, is that if you have seen enough referrals in your day, it's bicep tendonitis, scapular dyskinesia, and good luck. Okay, so like when I get a referral as a PT, I'm like, okay, this person either didn't do their due diligence or whatever. So don't need to go any more into that. Do I think that it matters? Yes. Do I think that it's like the only thing that matters? No. So again, this is where the nuance of being a clinician comes into play. So I agree with you. People have done extensive amounts of research and figured out efficiency across the whole body. So unfortunately, our anatomy isn't going to really change much in our lifetime. We're still going to have the same amount of bones. We're still going to have the same amount of muscles. They're going to be attached to the same places. So like all these new age, like clickbaity social media stuff, it's like, dude, our anatomy hasn't changed in 10,000 years. So I might as well like take into consideration people that are a lot smarter than I am doing their whole thing and trying to use that to the best of my ability to make the clinical decision. So do I think that it matters how they move? Yes, to a degree. Do I think it matters completely? No, but I think that's that's part of everything. So yes, I still use your quote unquote like first semester, hey, here are the amount of degrees of range of motion, here's how active range of motion. And then I use those norms to then make clinical decisions to the best of my ability.
Yeah, and I don't think you can be expected to do more than that. I think that's just a very honest, like, it's like you get what you can get and you do what you can with it. So I'm assuming you go from the kind of scapula, like looking at some, like you said, some 90/90s for anyone who doesn't know, like essentially elbows bent to 90, like doing like some abduction to 90 degrees, like watching scapular motion, as well as like forward flexion, seeing how the scapula behaves in different planes of motion. Where are you going next?
Then that's going to be kind of your clinical decision making of your differential diagnosis. So at that point, like
Okay.
I'm still doing that as part of like my movement screen. So then I'm taking all your passive range of motion. So then I'll take your shoulder ER and IR. I'll take your horizontal adduction. I'll do
Oh,
some of my kind of
interesting.
like capsular. Sorry, go
You
ahead.
measure shoulder adduction?
In horizontal plane,
Oh,
yeah,
oh,
yeah. So it's
okay.
so kind of the nuancy things, I guess, from taking a pure shoulder flexion of how they teach you is okay, grab the humerus, take them into full flexion. With my flexion, I'm looking at more of a capsular flexion. So I'll kind of guide, or I'll have my one hand on the scapula on the lateral border, then I'll actually grab the humerus, then I'll kind of take them into flexion, and I'm seeing where the scapula tends to pop in my hand. So it's kind of like getting a true flexion measurement as well as a lat and teres major kind of length test. So then it
Mhm.
gives me a good idea of kind of what's going on because in most baseball players there's a significant discrepancy and we're talking 50, 60, sometimes 80 degrees worth. So if I take that and I can literally take their non-dominant side and 180 no problem,
Hmm.
excuse me, and then their throwing side, like I just had a kid yesterday on my table at 95 degrees of flexion. So there are some nuancy things that I guess comes into treating or diagnosing like overhead stuff.
Mhm.
And obviously I can always plug the people that taught me how to do that, but that would be like one of the things. And then horizontal adduction, it's in the same plane, kind of take them up at 90 degrees of flexion. And then I'm actually kind of having my hand on the scap and then I'll take them into adduction to get a little bit more of like a teres posterior rotator cuff length test. So those are
Hmm.
kind of my I guess clinical pearls, I guess, for overhead athletes where it's a very specific testing protocol that I use for them, but I still use it for, like I said, for all other upper extremity patients because a lot of, again, anatomy is anatomy. Whether it's barbell overhead or throwing a baseball, it's most of the time it's going to be across multiple populations.
Yeah. Um, okay, very interesting. So for anyone wondering, is there a range of adduction where you're like, this is problematic or not necessarily problematic, but like you said, if you're doing it more as like a length test or like a tension test on the kind of posterior rotator cuff, like obviously the end feel is going to feel muscular. So for anyone who is wondering, like, what the freak is an end feel? Like a muscular end feel is like you push it, but it's not like it really restricts you. It's just like it becomes tight, and you'll push into it, and it'll just be like it's like just gets stretchy.
Correct.
So like at what point, like if you're taking someone's arm across their body, what would you consider, and again, I'm asking you to do things that apparently our research cannot do. Um, what in your mind is like at this point of adduction, like it's normal versus like, oh wow, I'm already getting a kind of end feel at this point. I'm gonna be thinking some treatments required.
Absolutely. Yeah. So the book says 45 degrees. So that's basically the crevice between your elbow. Like if you're going to kind of bend your elbow, like that crevice needs to kind of get to your kind of like chin line or mid
Okay.
face line. That's your quote unquote 45 degrees. Most baseball players, I mean, I'm happy if they're past zero. Like I had a kid yesterday on my table, he was -5. So it's like, okay, then but again, it's like I'm taking into norms, and I think this is where people can appreciate this once you start practicing is that yeah, the book has the norms, but the person in front of you has different norms. So like I'm comparing
Right.
everything to one side versus the other. So like if
Sure.
I do a horizontal adduction and the book says 45, but the other person's normal is 20, Okay,
Sure.
that's normal now. So like I don't okay, that's it. So this person that like yesterday he had -5, but his normal on his other side was 20. It's like he's like, yeah, he's off, but he's not that far off versus like a -5 versus 45. That's 50 degrees. Like that's way worse.
Hmm.
So again, it's just I'm just taking into consideration just the nuances of the person in front of me, but comparing it to the other side. So those are gonna be the big things as far as like cool. Now that's one thing. Obviously, manual therapy would be involved there and trying to kind of then become a clinician after that.
Okay. Yeah, awesome. So quick recap after our little tangent, like scapular mechanics, you're looking at that. You're taking them through range of motion, palpating the scapula to see kind of when it starts to move, and detecting how much real like glenohumeral flexion do they have. Like where is their arm really getting to before the scapula is coming in to take over. And then you're taking measurements. You're taking measurements of flexion, abduction, internal external rotation, and adduction, which I think is particularly interesting. I need to start doing that when I do get some shoulders. Where are you going next?
So at that point, I mean, I'm still going to look at the elbow at some capacity,
Okay.
even if it's a shoulder person. So like, I want to make sure they have full elbow extension. Baseball players tend to lose elbow extension over their lifetime, so you want to kind of make sure that you keep that. And then pronation to supination to make sure that the form is kind of doing their thing. So again, players tend to sit in a little bit more elbow flexion and tend to sit in a little bit more pronation over time, just because the muscular tissue tends to get a little bit more hypertrophic. So
Mhm.
just again, just note taking. So again, is that I'm just kind of when I cohesively explain to the patient what's going on, I'm hitting all these boxes. So, but going back to then, if it's more of a shoulder thing, then yeah, those are where kind of your quote unquote objective test measures and your special tests come into play. I do a lot of handheld dynamometry. So I do a lot of objective testing and then using those numbers against the person's body weight in order to make clinical decisions. So, for instance, one of the bigger measurements that I use in my practice is external rotation strength against body weight ratio. So
Hmm.
they should be able to externally rotate a certain amount of percentage against their body weight in order to make one to be quote unquote safe, I guess, from a return to throwing perspective. And then two is like, here's their baseline and here's where we don't want to fall underneath. So most of my players that tend to have some sort of shoulder elbow pathology tend to sit anywhere from like a 12% to 15% ER to body weight ratio. I don't allow somebody to pick up a baseball in my office until they're north of 17%. I don't discharge them from PT unless they're closer to 20, 22%. So again, it's just taking that in consideration. So objective handheld dynamometry, shout out Vald's Performance and Health. That's I use their Dynamo. It's probably one of the better ones on the market. So
Sure.
it's good, it's accurate.
Would you spell that so that I can put a link to it?
VALD, Vald.
VALD. Okay, and you said you had a specific model that you like?
Yeah, it's called the Dynamo. It's just a
Dynamo.
handheld a dynamometer, and
Sure.
it's great. I use it all the time.
Any idea what it's going to run someone if they want to get one?
So
And
they
for
do.
anyone listening, it will likely be expensive, but you only need to buy one. So,
So funny story about that. So you actually, it's a subscription model. So
okay,
their kind of selling point is that you're paying for the back end work and all the back end help from their systems perspective. You're not buying
rather
the
than
device.
just a scale. Sure.
Correct. So, like, if you wanted to buy the device, I would say either the Lafayette is probably going to be the best one in the market. That runs about 1,500 bucks, one time
Okay.
purchase. Cool. The Valds, I think I pay like, it's like 70 bucks a month and it's a 3-year contract. So, within that ballpark, if somebody's looking for that, I still think it's a good one because it allows a lot of different testing and different testing protocols.
Sure. So I'm pumped. So I'd never heard the external rotation to body weight ratio. Where is that something that you came up with? Is it something that you found? Like where did you get that?
So my baseball upper extremity quote unquote mentor is Mike Reynolds. Most people that have any
Oh,
idea as far as
really?
sport,
So
yeah, so
you know
sports
Mike.
rehab. Yeah, yeah, yeah.
Oh,
So
cool.
did one of my rotations with him. So if you do any type of research or anything at all, he's cited in a lot of different research. His mentor is Kevin Wilkes. So when you talk about the person that's done probably more sports rehab than anybody ever will in their career, probably times 10, is that's where that came from. So he published a paper. I wanted to say, I mean, you can find it. I don't know the name of the study off the top of my head, but they basically took a bunch of dynamometry testing and then they came up with quote unquote norms for baseball players to be as efficient and as clinical decision making as possible. So ER to body weight ratio, ER to IR ratio,
Okay.
and various others as far as like total arc of range of motion and this whole thing. So I would say if you're going to kind of go look at research articles and try to read up on some of the stuff that I'm talking about, those would be the two guys that I would probably try to go find.
Cool. For anyone listening, I will try to find that research article and include a link to it in the notes. That is excellent. Yeah, because I think that's super helpful. I always played volleyball growing up, and I've always been looking for some type of norms for overhead like throwing type athletes. And I know it's
Yeah.
baseball specific, but I mean, it at least gives you an idea, even if you work with other types of throwing athletes. Kind of again, you can't generalize it, but it's good to know there's some type of norm if you're going to be doing a lot of throwing as an athlete.
Oh, absolutely. And I mean, I still use a lot of those norms for instance, like I have a post-op rotator cuff on my
Mhm.
table CrossFit athlete, and she's 55 years old. So it's like I'm still using those relative norms and then also then comparing to other side to make clinical decisions. So yeah, I use them for throwing athletes, but they're still applicable for most other cases as well.
Well, sure. Because I mean, if your rotator cuff is strong enough for you to throw a baseball at max velocity and return to playing, it's probably okay for you to go back about your business.
You would think.
Okay. Okay. Awesome. So you use dynamometry a lot, and let's just cruise down to the elbow. Like
Yeah.
let's not like silo this person as a shoulder patient. Like if you're going down to the elbow, you said they often lose motion. Do they lose motion because of more of a soft tissue, like there's just hypertrophy around those tissues that are protective, or is there more like joint changes, or like is it more like passive, like thickening and restriction, or is it more like an active structure has hypertrophied and is limiting things?
A little bit of both. So with
Okay.
elbows and high velocity elbows, I mean, we can get all the way into osseous changes. So we have osteophytes that are being either chipped off or are forming in order to kind of create some sort of stress adaptation to velocities and high stress.
Mhm.
Most, I would say, from a soft tissue perspective, most of them is going to be, again, so kind of what I alluded to earlier is you tend to sit in a little bit more flexion and tends to sit in a little bit more
Mhm.
pronated position just because the bicep from an eccentric loading standpoint into the follow through. Pronation, your wrist actually tends to pronate as you release the ball. So pronator teres and flexor mass tends to get a little bit more wound. And those are going to be the highest stabilizers for medial elbow stress during the throwing motion. So it's a natural adaptation for the body to create some of these, whether or not it's a soft tissue restriction or a hypertrophic change or anything of these nature where the body's just trying to protect itself.
Sure. So you're going down to the elbow, looking at range of motion, flexion, extension, pronation, supination. Um, and you're using some dynamometry. Is there any specific dynamometry stuff that you're looking at for the elbow?
So I've actually started to kind of ask some more questions around this because there's not a lot of
Mhm.
good research out there on there. So with my dynamo, I still do a standard grip strength, so 90-90, the whole thing. That's going to be your general basis of kind of what's going on. Obviously, there's some research articles out there where FDS, FCU, and FDP are going to be kind of these musculatures that have either a very, very close direct attachment to the UCL or to the medial epicondyle, obviously, but the testing protocols on those are pretty poor. So, right. So, like
Yeah.
fourth finger digit flexion or DIP, like it's a really hard testing protocol, and I don't think there's a good one out there. So, I still do standard grip strength, and that's probably really the only one I really do for the elbow. One that I'm kind of flirting with the idea and collecting some of my own data is doing a grip strength test at the 90-90 position up overhead.
Hmm.
Again, preliminary data, it is all subjective at this point, but I see about a 10 to 15 pound discrepancy between your normal 90-90 grip strength test and then the same test up at 90-90. So again,
When
trying to get
someone's
as
injured.
not even when someone's injured, just
Oh,
standard, like
just
across
because.
just
Okay.
because. So then, but then it's like when we start doing like your quote unquote return to sport testing, they spend all their time here. So like I should probably test some things there. And
Mm.
again, is that if we're talking about lack of medial elbow stability and strength, and I don't know why there's a strength discrepancy that much at that position. Obviously, you can make the argument with co-contraction with the lat, subscap, and all that will create more of a flexion bias, which will therefore a little bit more strength, and this is less of that maybe. But to answer your question, is there's not a lot of good elbow protocols from a strength testing standpoint out there.
Okay. Is there anything you look at particularly with the wrist?
To be honest with you, not too much, unless
Okay.
it's kind of one of these things where somebody comes in with some wrist stuff, then obviously I'll look at, like, for instance, I have a kid on my table, Division 1 baseball player. He had a TFCC issue, and then that led to a hamate issue, which, okay, different topic of conversation, but yeah, like that was a whole thing where, okay, cool, like I'm doing your glides. Do you have full extension? Do you have full flexion? How's the radial head moving up at the elbow? So like, yeah, like there are times and places to look at the wrist, but from a general orthopedic standpoint and treating baseball players, the wrist doesn't really have much indication unless it's like a nervy type thing where they're getting some numbness tingling in the fourth and fifth, which tends to be pretty prominent in baseball players, or God forbid if it's like a really gnarly, like a TOS situation where median nerve involvement, neural entrapment, or vascular entrapment, something of that nature.
Sure. And yeah, so that adds a couple good questions. Like if you are getting a baseball player or and they are getting numbness, tingling, or other things going down into their hand, how are you clearing red flags for that?
So again, going back into we are a doctoring profession for a reason, so we need to kind of
Mhm.
know some of these things. So again, taking a good subjective, kind of seeing what the route of that is. So most of the time, I'm gonna bucket this just to make it easy.
Yeah,
But
please.
if I hear an ulnar nerve kind of issue and they have medial elbow pain, I'm not super worried because of the way that the ulnar nerve runs through the cubital tunnel, the irritation that comes from that, from the valve gets stressed through the throwing motion. I'm trying to see if I do a soft tissue tension test, a nerve tension test. Most of the times the ulnar stuff will probably subside unless it's something else, which cool, I need to clear that out. The big kind of red flag kind of issues that I'm always hearing is like, oh, my arm goes numb, or my arm goes dead, or my arm is, I just don't really feel like I can hold onto the ball very well. Words like that, I'm like,
After throwing, like for a while,
just
or just period?
just period. So like
Okay.
there are some TOS cases where they're like, yeah, like the first couple throws are good, and then I just start to like lose feeling. So then
Hmm.
obviously then I'm thinking more TOS and some other system involvement, or God forbid if it's like then backtracking. It's like if they're coming in with ulnar stuff, I'm obviously need to clear cervical, which obviously wasn't discussed, but let's just rewind and insert back that
Sure.
I do look at the cervical side when I do evaluate a patient, but again, nerve stuff, I'm not necessarily thinking that it's at the direct site of where their issues are. I'm probably thinking more proximally.
Awesome. So let's kind of clip that in. We'll just kind of throw in the cervical spine for a second. Do you find that there are common limitations in the cervical spine with baseball players that are having some type of pain?
Oh, absolutely. So over the nature and just again, kind of going into the idea of baseball throwing is very stressful. The body is very smart and it creates some systemic adaptations for the lack of a better word. So
Mm.
scalenes, SCM are going to be they're going to be kind of gunky. I use the word gunky. Some people get it, some people don't, but like
Technical term.
it's exactly. So the musculature is just, it's very poor. The muscles feel really gritty. They don't really move very well. They just don't really feel very good. So I would say like SCM scalenes on their throwing side, on their dominant side, are going to be a little bit more wound up. So obviously that would lead into ipsilateral rotation tends to be a little less, um, or it's like a very like aggressive stretch feeling when they go to the contralateral rotation side. But yeah, so like systemic like trap kind of on that upper quarter into the neck cervical area tends to be a little bit more something I'm aware of on a thrower's athlete, but most of the time is sometimes it comes into play and sometimes it doesn't. But yes, to answer your question is you can see some systemic changes in the cervical areas with throwers.
Sure. So after going back, so we'll just kind of jump back. So after you after you do range of motion and strength testing, where are you going? Are you doing like upper limb tension testing? Are you looking at joint mobility? Or at that point, are you from your approach most of the way done and you're looking for these buckets?
I would again, I think it goes into the subjective, but I'm not. I mean, rarely am I doing a upper limb nerve tension test for most athletes because again, it's that
Okay.
like I tend to sit in the corner where if a nerve is pissed off, there's probably a reason why it's pissed off. So like I'm not gonna just, oh hey, stroke my ego a little bit, like, oh hey, here's this ulnar nerve tension test. It's this cool little test, and oh
Like,
yeah,
it's
I'm just lit up
positive.
this nerve.
Yeah.
Yeah.
It's like, I'm so
So
good.
yeah, so it's like at that point, at that like again, going through a systematic evaluation, once you kind of get towards the end, you should at least have some sort of concept of why something is happening. There are times, and I'm upfront and honest with my patients, where it's like, dude, I have no idea what's going on. We're going to try a couple of these things and we're just going to kind of see what happens. But for the most part, is by the time I kind of get to these quote unquote times for special tests, I should have about a 97% chance of, nope, this is what's happening. So at that point, it's, I either make the decision where it's patient education or whatever the case may be, if I need to just do one or other, like one more test just to confirm or deny my bias. So, but yeah, joint mobility is something I'll do capsular stuff through the shoulder. Uh, but at that point, it's kind of just putting the bow on the last little part of the present.
Do you find that you have to look at the AC joint or the SC joint very often?
Not very. So
Okay.
funny enough is I actually had a patient come in probably about 3 months ago, and he got tackled playing football, and he had a tournament that he needed to get ready for, a big tournament out in Arizona. And he came in, he's like, dude, my it hurts right here, and he's pointing at his sternoclavicular joint. I was like, dude, that's like the strongest joint in the body. Like, if you upset that, like, there's not really much I can do. But at that point, it's like, okay, cool, clinical decision. Can you move a shoulder? Does the clavicle kind of rotate well? Does it slide and glide? Is there any AC joint pain? Is there a fracture? Is there? So I did my due diligence to kind of figure out what was going on. But like at the end of the day, he was basically negative with everything. He was just like,
Mm.
dude, it just hurts. It hurts when I rotate. I'm like, okay. So we did some stuff, and I kind of unloaded some stuff, and he's like, "Yeah, it still hurts." I'm like, "Well, I think that the joint's just just mad." So,
Pissed off.
but yeah, so the sternoclavicular joint tends to be somewhere like that's very, very rare, and even research would support that as well. AC joint stuff, again, I think it's one of those bucket diagnoses where, oh, it's AC joint pain, or it's shoulder impingement, or it's this, that, and the other. I think it's a BS term, and it kind of needs to come into this more of like why is it happening, not what is happening.
Sure. So I love that you have buckets. I'm a big proponent of buckets. And we're already over an hour, so we're not gonna
Yeah.
go. I mean, we can go as long as you'd like. I mean, I do have a life, I promise, but I'm also willing to be on here as long as I need to be. Um,
Yeah.
can we talk about? I'd love to talk about these buckets a little bit.
Yeah.
And maybe not even just buckets related to the upper quarter like we've been doing. I think those will be important, but let's also throw in some buckets for kind of lower quarter because like you said, it's
Yeah.
a full body screen. Like
Yeah.
we have to get away from like, well, the shoulder hurts, so I treat the shoulder. It's like, why is the shoulder hurting? And for anyone, again, I use this a lot. For anyone screaming at their speakers right now, we were like, we don't know why it hurts. It's biopsychosocial, right? Maybe it's like, but we
Yeah.
don't actually know that's true until you're so good at your job, you've cleared out everything that you should be competent at doing. Um,
Correct.
so what are these? We'll start upper quarter. Like as you go through the assessment, like what are these buckets? Because I don't think that triage I think people hear triage and they immediately think medicine. Physical therapy, triage is most important. If they have five limitations or dysfunctions that you find, like there could be one, like two of those that are actually just caused because of another dysfunction. We
Yeah.
need to be better at triaging what are the things that are most likely contributing the most to the problem.
For sure.
So I would love to hear about your buckets. Like what are these big buckets that you're like, if these things pop up, I am going to address that day one because
Yeah.
that in my opinion is likely if you'd agree that's going to determine how you're intervening first session.
For sure. So I'm gonna kind of go through like the highlighted ones that I can kind of think off my head. But
Yeah,
glute med
that'd be
weakness
great.
is, I would say, across all sports, that's going to be a big, big component for lower extremity stuff. So obviously, then that would kind of show up from a movement screen standpoint of valgus at the knee with squats, lack of accuracy with lunging, like those characteristics would kind of show their head. But glute med weakness, I think is going to be a big bucket that I'm kind of always aware of. Shoulder range of motion from an ER and IR standpoint is it tells me a lot, right? So if they don't have a lot of internal rotation, is it a post cuff issue? Is it a humeral retroversion issue? Is it there's a lot of things that I'm getting out of there. Hey, is there massive discrepancy between right and left? Most of the time there is. So that's where my manual therapy techniques would come in, and then patient education around, hey, here's soft tissue work, here's a lacrosse ball, here's a foam roll. There's that whole situation. Lack of flexion is going to be probably the new thing that tend to people like it's one of those things like it's so hard for me to rationalize that it's even I don't want to say missed, but just at the ASMI conference that I was just at a week ago, they're like shoulder flexion is the biggest indicator for shoulder pain or lack thereof. Shoulder flexion is the number
Hmm.
one indicator for baseball related injuries in the shoulder. It's like, okay, well, yeah, that makes sense because the lat is the biggest body or biggest muscle of the upper body. If you have a issue with the lat, extensibility, strength, this and the other, then that's going to affect the humerus, which will also affect the scapula, which will then, God forbid, it'll probably affect something else somewhere else as well. So I would say like
Can
those
I
are my
interject real quick?
for sure.
So when it says limited flexion, does it mean like if the scapula is pinned, like you're testing flexion, or does it mean
Correct.
global
Yes.
flexion?
So if somebody has a lack of passive range of motion flexion, they probably have a lack of active range of motion flexion as well. So
Okay.
that's where the nuance of that, and maybe I can film a video or send it over, but it's like if somebody can't, like a lot of baseball players, they'll get up overhead and I'll test them overhead and like one arm goes way back and one of them kind of stops and they'll be like, oh yeah, I'm the same on both sides. And it's like, dude, you're acting like 30 degrees of range of motion. And I'll take a picture of it and then I'll show them. They're like, oh, and I'm like, okay. And then again, then I confirm it with the passive range of motion test. But globally is that, yeah, like if the lat or whatever the case may be is limiting flexion, then that'll probably be a compensatory issue maker later on down the road.
Okay, got it. So you're like, and just maybe I didn't understand. So you're pinning the scap, passively range, like lifting checking the glenohumeral motion. And if that's
Correct.
limited, that is likely a big contributor to their shoulder pain.
That
But
is 100%
also,
correct.
if that's limited with you passively moving them with the scapula pinned, it's unlikely they're going to have full motion actively anyways.
That is a very concise summary. Absolutely. Yep.
Okay. Okay, great.
Perfect.
Yep. Keep going with your buckets.
Yeah, so I would say those are like my big massive three, and then I would say my fourth would be objective testing with the dynamometer. So rotator cuff tends to be weaker on the dominant side. Again, I kind of use the metaphor as like a bank account. So throwing is a withdrawal, recovery, sleeping, eating, everything else like that tends to be more of a deposit. Most of these kids are pretty poor in all of those buckets. So
Mhm.
that's another biopsychosocial thing that we can talk about later. But rotator cuff strength, I would say, is I would say the biggest golden bucket that I probably tend to see just because these kids are their bodies aren't made to tolerate as much stress as they're asking. So then therefore the body starts screaming and there's pain there. So I would say out of the four buckets, like out of the buckets that I tend to see most often, those are going to be the four that probably poke their head the most.
Excellent. So, in case some people are going to be curious, so I'm going
Yeah.
to go over this again. So, external rotation to body weight ratio, in case anyone
Hmm.
forgot, like people that are injured, you're probably looking at 12 to 15% or less.
Correct.
Um, in your opinion, you kind of stick around 17 or more. Like 17 is kind of the cutoff where it's like you can start picking up a ball and doing some throwing again. And return to sport, you're looking at like 20 to 22% or more external rotation to body weight strength. Do you, off the top of your head, happen to know the internal external rotation ratio?
Yeah. So research and in that Kevin Wilk article is 66%. That's the norm. I'm kind of changing it.
External to internal?
Correct. So say for
Okay.
instance, if somebody externally rotates at 25 pounds and then they internally rotate at that, what would that be? Two thirds, it'd be like 60 pounds ish. That'll be around that 66%. I think if my math, I don't think that math is right because
That's
50 would
okay.
be,
Let's do
yeah,
100. So if internal rotation is
perfect.
100, external rotation should be 66.
In theory, yes.
Okay. Got
Because
it.
then if you divide 66 by 100, it'll give you two thirds.
Okay.
So
Great.
with that being said, is I'm changing that slightly in my practice currently. I want closer to probably 72 to 75%. So that external rotation metric should be a little bit more than probably what research says. But again, that article that they did this, I think it was published either in the early 2000s. I would probably say it was like the early 2000s. So if they were to redo that, I think that they probably change their numbers.
Okay, awesome. So, I guess my last thing. So, for anyone listening, we're not really going to get into manual interventions, because if you are someone who does manual interventions, um, and you're going to address manual limitations in whatever way you do, and that's also really hard to describe and effectively help someone perform
Yeah.
on a podcast. So if we could use our last few remaining minutes, and
Yeah.
go through these buckets quick, I feel like everyone has their favorites. So let's go. Glute med. Do you have some favorites? You're like, oh man, if someone's got med weakness, I always like maybe starting with like X, Y, or Z. How are there some exercises that you preferentially like to start and maybe progress through, to address that?
Oh, absolutely. So I guess now going back to your metaphor thing earlier on in the podcast, I'm a massive two birds, one stone person. I
Yeah,
want to get as much bang for my buck with anything that I do in the clinic as much as I possibly can. Obviously, I think that dictates how I practice one-on-one cash-based system versus other. But anyways, if I'm going to go into the glute med weakness, I'm going to try to see is the first question I'm asking the subjective is, are you working out? That I just want to know, like, are you even lifting? Because if you're not even lifting, cool, then if it's a 12-year-old kid, we are going to learn how to squat perfect. We're going to learn how to lunge perfect. We're going to learn how to do that because again, I don't know if I want to work the glute med in isolation because if I teach them how to lunge really well, now we're talking about movement accuracy. Now we're talking about balance. Now we're talking about strengthening, and then now I can load it. So a little bit more of a nuanced thing there, but
Mhm.
at the same time too, it's like let's just say yes, they are working out. Cool. I need to get inventive. I will still have them do like a side plank clam or a side plank just in general because it's closed chain glute med strengthening. But then I can have them do a side plank while they do some sideline external rotation and do the same thing at the same time. So now we're
Sure.
getting glute med, contralateral glute med, and then we're getting rotator cuff strengthening, which is in theory your sports specific exercise that looks
Mhm.
really good on Instagram. So again, I would say a lot of closed chain movements tend to be my preferential route to strengthen the lower extremity.
Okay, cool. So like side planks, lunges, squats, depending on their proficiency. Um, and for your shoulder range of motion, internal rotation, external rotation deficits. Again, if it's a joint related issue, someone should be able, with their skill set, mobilize it in some way if that's something they believe in. Are there interventions other than joint mobilizations that you really like for internal external rotation deficits?
Funny enough, I don't do a single joint mob ever. I am
Oh,
not a
okay,
joint mob. I am not a joint person at all.
okay.
So going back to the whole neurological thing and kind of that route, what I tend to see is that I think soft tissue structures affect the joints a lot more than the other way
Then
around.
the other way around. Sure.
Yeah, so I tend to go after more neural sensitization or desensitization. I go after more soft tissue structures. I go after more trigger points. I go a lot more off of that type of stuff first.
Mhm.
Then the joint stuff tends to clear up pretty well. Again, I'm very proficient on joint mobs. I do them. I'm not saying I
Sure.
don't do them
Sure.
ever, but I tend to clear more soft tissue structures first. So going back to the lack of internal and external rotation, most of the time in my clinic is that they're going to have more external rotation on their throwing side than internal rotation,
Okay.
which if you just think about it from an anatomical structure is that if they're lacking internal rotation, it's probably the posterior rotator cuff probably a little bit tight. Cool.
Mhm.
Desensitization, trigger point, lacrosse ball, whatever method you feel is appropriate, you'll
Mhm.
probably get another 10 to 15, maybe 20, 25 degrees more just doing some good soft tissue work.
Sure. And many people are curious, what does that look like? I know it can look like various things. If you're giving them a
Yeah.
lacrosse ball, how long are you having them lay on it like static? Are you having them dig it around on a wall? I'm sure that though all of those things are included, do you have kind of a baseline where you're like, I'm going to start having you do this, or I'm going to start digging my thumb into it for a minute? Like, do you have the general thing place you start if someone has like a posterior capsule tightness or posterior shoulder tightness? Because I agree, a lot of external rotation, limited internal.
Yeah. It depends if I'm doing it manually with my hands or if I'm teaching the patient. Most of the time, I tend to do like long static sustained holds. The When you're doing the rolling, if you kind of think about it as like a wheel or a circle, is like, let's just say like one like sliver of that is like the painful part. Every
Mhm.
time you make a circumduction, you're only going to hit the problem spot once
For
every
yeah, for a
circumduction, right?
second. Sure.
For a second. So I tend to go like, hey, find the spot that sucks the most and just hang out. Because what's going to happen is it's going to kind of like the brain and again, the gate theory is getting some heat right now, but you're going to get a massive sensitization and then it's going to go down into a desensitization state. So
Mhm.
I tend to tell my patients is like, do that first. And then once you do that, okay, now go roll and then get the muscle because it's going to be a lot more of a better environment for the muscle to relax versus this like, oh, let's just hammer this thing home and then you kind of go from there. But yeah, but the method of that, I don't really have any preferential method. Again, hypervolt and all these massage guns, and like I don't care. But I will say is that when I'm teaching a patient is I want them to use a lacrosse ball first. It's
Mhm.
easy, it's accessible, and they learn how to do it, which is a massive part of my practice where it's like I'm trying to educate patients on how to take care of themselves.
Sure. And last bucket, well, dynamometry, I mean, strengthening is pretty straightforward. Let's go to your shoulder flexion one. What do you like for shoulder flexion? And then we'll wrap up.
Yeah, same situation. Like the lat is, it's still a muscle. It's a really hard muscle to get to, but between a foam roller, a lacrosse ball, or a good one that I tended to use a lot is it's like a bench lat mobilization. So they'll take a
Hmm.
PVC pipe. Eric
Mhm.
Cressy made this one pretty popular along many years ago. So they'll use a bench, they'll put their elbows on the bench, and then they'll kind of mobilize posteriorly, and then that'll kind of help elongate the lat that way. But I mean, it's again like if I were to kind of summarize how I treat baseball players is I'm throwing the kitchen sink at them. So like yeah, like even if there isn't that much of a limitation with the lat, I'm probably still gonna have them do it because I know the lat gets beat up all the time.
Sure.
So I would say there's many different routes of or many different ways to skin the cat, I guess, of how I kind of approach all these deficits.
Sure. So awesome. Like I don't really even have that much to say, which is uncommon for me. I'm a bit of a talker. So guys, I guess the biggest thing to do if you still have questions or you'd like to know more about Zach, like please go check out his Instagram page. It's Forged PTP on Instagram. Um, he's posted quite a bit of content. And then Zach, this is just kind of your time to kind of close out. If you have any kind of final words, you want to rant about anything, I've one question. One question.
Yeah.
Everyone wants to know what has been one of the kind of most influential courses or books or mentors that you have interacted with. People really want to know that. Anything stick out in your mind?
Yeah, absolutely. Obviously, I need to kind of preface this with it doesn't really matter as long as you're gonna do it on your own. So I'm gonna kind of let that kind of ruminate here for a second is because like I've had some really good mentors and I've had some quote unquote not good mentors, but the
Mhm.
bad mentors are still good mentors because I learned what not to
Sure.
do.
Sure.
So I think every progress, I think take that in consideration with whatever course or anything you're looking at. From a pure baseball standpoint, obviously your really big heads are going to be your Kevin Wilkes, your Mike Reynolds, your Eric Cressy's, some of these people that have been putting out content for, I mean, it's going to be close to 20 years. I would say that's very specific. But if I were to kind of give a guy that's doing like, if I'm going to give a shout out to anybody that's doing the most amount of content, probably in the best way possible, it's going to be my guy, Dan Pope, fitnesspainfree.com. He puts out more content than any human being on the face of the planet. Yeah, is it sports specific? No, but it's like for a student or for a PT that's trying to get in a new thing, like he's probably the smartest human being I've ever come across with when it comes to PT. So like that would be somebody where it's like that would be somebody I would really start to digest what he's putting out and trying to kind of take that home. And he has some really great like free guides on like he's basically made like like the clinical clusters like hey here's a sciatica test or a
Mhm.
rotator cuff test. He's done that for everything. So like
Oh,
ACL, rotator cuff,
awesome.
labrum, like it's out there. So if I'm going to give a shout out to anybody, it's going to be Dan Pope.
Excellent. So it's Dan Pope, and his website is fitnessmadefree.com.
Fitness pain free.
Fitness pain free. Got it.
Yeah, so on
Fitness
Instagram, it's
pain
fitness
free.
pain free, and then all of his resources are on his website, fitnesspainfree.com.
Okay. Awesome. So any closing marks, any closing thoughts, Zach, and we'll finish up if you want to, again, if you'd like to say your kind of business,
Yep.
anything you'd like to plug for your own purposes, anything like that, and we'll close out.
Yeah, I'm pretty accessible. Shoot me a DM anytime. Like I said, I really hope that I consolidated my thoughts. Obviously, there's a million thoughts going in my head at any given moment. So if you guys have any questions, comments, concerns, issues with this podcast, want to have a discussion, shoot me a DM. I'm pretty easygoing in regards to that. So I'll be more than happy to kind of walk you through or open a conversation. And then again, it's at forged PTP or at forged PTP on pretty much every platform.
Okay. Awesome. Well, again, Zach, this has been sweet. I've been trying to take more notes, and I'm gonna have to listen to this again because well, yeah, I'm like I should have written that down, but now we're already cruising. So this has been awesome. So again, thank you so much, Zach, for being here. Thank you, everybody, for listening.
Thanks for having me.
Absolutely. And for everyone else, as always, happy to have you. Take care.